Thank you so much, Dr. Cooper-Stock. And now I have the pleasure of introducing Dr. Thienemann, who we heard from yesterday with some really practical, hands-on education and information about how to cope with our children in the school setting and in the home setting. And she's going to share with us now about the development of her PANS clinic.
So again, I said, well, really, is this what you really want me to talk about? And I felt self-conscious about showing home movies. But I think part of the reason that I was asked to talk about this is, I think I say, why don't we have a PANS clinic? We want a PANS clinic. And ideally, I mean, you'd think there's some sort of institutional, omniscient planner that would say, yes, of course, we need a PANS clinic. Let's just make one. And that's not been my experience in reality. So I will show home movies, in a way, in hopes that by learning about what happened where I work, maybe you'll get some ideas that will help you, help your region or university or any kind of institution to try to get a PANS clinic. So here's the timeline. As you know, PANDAS was described by Dr. Sweeto, and some physicians, including Tanya, including Madeline, started treating and researching about PANDAS. Parents who both knew about PANDAS and didn't know about PANDAS had their children really sick and looked for treatment. Parents started connecting with each other. And in my area, a woman, Diana Pullman, and others started a parent website, the PANDAS Network. And Keith Moore and other parents developed the PANDAS Physicians Network. And these people were very active, and they were talking to doctors, saying, well, do you think you should see PANDAS patients? We think you should see PANDAS patients. Would you make a PANDAS clinic? They had bees in their bonnets for reasons you can understand, I think. The controversy developed, as you know about, but you know also about the meeting where people convene and try to collaborate, try to agree on what is PANDAS and what to look for and how to look at it. So where I am in Palo Alto, 3 academic clinicians each had interest in PANDAS for different reasons. Dr. Frankovich is a rheumatologist, pediatric rheumatologist, who had been interested in vasculitic autoimmune encephalopathies. Kiki Chang is a child psychiatrist interested in bipolar mood disorders. And I was interested in obsessive-compulsive disorder. Each stepping outside of their discipline, and of course it's such an exciting opportunity too to learn more, and of course even more so to help people. Each of us had enough interest in it that we donate a lot of effort. We would see patients on our own time. We saw patients in a clinic that was really, we're so lucky to get some space dedicated. But as I told you yesterday, it was very hard to see our patients who were actively ill in a nice kind of clinic where actually kids were kind of sitting still, partly because they were maybe really had a fever or something. They were feeling sick, and our kids were much more active and sometimes really not wanting to be there. But we tried, and they let us for a bit. And we had to see patients in an institution where some of the divisions thought this was not the right thing to do at all. They didn't think it was a reasonable thing to study or a reasonable way to diagnose some of the patients. In fact, there are divisions to which we would not refer our patients for consultation because we knew that it would not be well received. But we always had the local parents really behind us, which is helpful. So I have to say that Dr. Frankovich, my colleague, is very resourceful and dogged. And if you want a PANS clinic, you'll probably need to find someone who's resourceful and dogged and a good canvasser, a good campaigner. So she worked in her own rheumatology division and tried to get alliances and interest. She worked in her department of pediatrics, meeting with all the higher-ups to try to get them excited. She had to work with hospital administrators because money is obviously a big bottom line issue in almost anything you do. So you can't do much of anything without some money, because money is space, money is time, money is support. She talked to potential donors, and she talked within the scientific community, both at Stanford and nationally. To find space, to find administrative support, you need people to answer the phone and make appointments and enter it into the electronic medical record. You need some salary support for physicians and everybody else, and research support, because it's important to treat these patients, but as you know, it's really important also to do research to learn how to treat them and identify them in a better way. So this really feels like home movies, but I'll do it. So we started out with 2 half days of clinic space and administrative and nursing support in the room clinic. Jenny worked half a day, sponsored by her division. Kiki worked half a day, permitted by child psychiatry. And we had a full-time administrator, which was absolutely a godsend. Jenny got more time funded for both administrative and research time, up to half a time more, or altogether. And this permitted the start of a database, which we are using to put all the information that we get, and we're hoping to use that, we are using that to help with research. We moved to a clinic space where we had our own exam rooms, our own assistants, our own nursing, and it was very nice because our patients could be who they are, and that was not any obstacle really to treatment. We got a full-time nurse practitioner who had a primary care background, which is fantastic because the physicians had such limited time, half a day a week, or I'm finally up to 2 days a week, that we all have other jobs, fielding all the calls, checking all the cultures, checking all the labs, refilling all the medicine, and seeing people urgently. It's been wonderful to have a nurse practitioner. We also have an educational consultant who the Children's Hospital allows to come and help with us and our patients, which is just very lucky, but it's not really lucky. I think it's the hard work of especially Dr. Frankovich. And lately, we've been collaborating with a hospital nearby that has a new pediatric ICU, where every ICU bed is its own room, and every ICU bed room has a bed for parents. And it's nice and quiet, and it's, only as light as it needs to be. And so we will be able to use this when we'll need to have people hospitalized for any more invasive treatments like IVIG or plasmapheresis. And we're going to get an immunologist and an immunology fellow in the fall. So this is just a schematic of how we've grown, which is a nice line, and it's going to keep going up. How did it happen? Well, we had some physicians with really, really strong interests for personal, for professional, for inspired by certain patients, seeing a turnaround, think, I just have to treat this. I have to learn more about it. We piloted a clinic on a shoestring. I worked there for free for half a year, for about a day a week, and to give some proof that it could work, just like any kind of business. You have to show that it can work with enough flow and enough revenue. You have to politically and financially do some effective campaigning. people have to accept in the institution in which you're trying to do this, I don't know if it's a freestanding clinic, then that would be easier, that will be, you're doing something that is reasonable, scientifically supported, and that can support itself. So we're really happy, really exist, and we're working very hard, and as a result of more and more people being aware of PANS and PANDAS, we have had a huge number of people calling for help from all over. And we have quite limited staff and resources altogether, even though they're much better than they were. So we've had to really have circumscribed intake criteria for our clinic, which is unfortunate. All of us would like to see everybody who calls, but it's been impossible. So we've created research goals, clinical research goals, which we think will expedite the finding of the causes and cures of PANS. So in the future, more clinicians and academic centers will care for patients with PANS. So it's a short time loss that we're not seeing everybody real time that we would like to, but we hope that we will find things or help find things that will help more people. So we've had to shut down to a 90-mile radius. We can't take anybody who's outside that radius. You don't want to do phone treatment. Really, that's something that doesn't feel like good practice. And so we started out with a bigger radius, and we have narrowed it down to 90 because that's kind of a reasonable-ish drive that people won't have a large threshold about doing if they have to come in that day, for example. We've had to have a limitation that patients have to be referred by their pediatrician or other primary care doctor with whom they've been established in treatment for at least 3 years. Now, of course, if they just moved, that's will be reasonable, but working physician to physician is also an expander, because if we can work with that physician and their patient and hope we will get a good result, then we have now helped incorporate another collaborator, believer, someone who feels competent in treating. So that's one of our criteria. They have to meet criteria for a PANS clinical observational or a PANS interventional study. So making this database is the operational part. And we see people, we're called by people who have had the problem for a couple of weeks or less and for a decade or more. And I want to see them all. In my private practice, I have to have an assistant because I can't take the phone calls because I will say yes, and then I won't be able to see my patients that I already know. Because we want to research the narrowest band of defined PANDAS, we are unfortunately not taking many of the people who call, but we're taking the people who have really recent onset, for example, just soon after they get sick as possible, because we want to learn as much as we can about that narrow band before we look at a more mixed sample, because even within that band of people who have really acute onset really recently, there are differences in them. We see some of them who have different problems with immune system function, for example, than others. We have some of them who have different HLA types than others. It's still going to have a lot of different kind of people, and to do good research, you have to have enough subjects to show differences. And if you have many, many, many different variations, you're going to have less subjects in each pile. So we were just trying to be most efficient as possible. Rarely we make an exception for someone who we think is someone who will be interesting research-wise in terms of being able to contribute something in addition to the knowledge about pants. That's a really unfun part about it, is saying, we can't see you. So here's what we do. For intake, we have a pediatrician referral, and we have a screening checklist that the nurse practitioner will do. She will review the intakes, and if they seem to meet our classifications, then they will get an appointment. If not, she'll run the intake by our team to see what we think. If accepted, the patient's family gets all of the medical records, and that's not just being silly with that picture. We really want to see all the pediatric records, all of them, because we go through them page by page, and we try to write the story, especially looking at, obviously, history of infections, history of behavior issues, like on a 3-year-old well child visit, what did they say about behavior? Were there any changes? Was there any kind of infection antecedent to that? Very interested in family history and, of course, sudden changes. Then whoever's reviewing it writes a write-up so that we can all read it before we meet the patient. We are collecting data in a PANS questionnaire. The patient registers, and we also have the family members register. In case of the likely situation, we would ask the family members to also get checked for strep. Now, if their insurance doesn't work at where we are, we would send them to where their insurance will get a very good throat swab. But it's hard at the end of the visit if you say, oh, we need to check your throats, and then it's 5 o'clock, and then the administrative staff is about to leave. So we try to get that ahead of time. We review and clarify the history in the chart review. We fill in missing information. And we ask about the following: issues of current infections in the family, past strep infections, just recurrent illnesses, hospitalization for other type of infections, recurrent strep infections, tonsillectomies, heart valve replacement, as in, did they possibly, their grandparent have rheumatic fever, arthritis and other autoimmune conditions, and psychiatric illnesses and tics. We also ask the parents to fill out a caretaker burden inventory. And I can't remember who said it, maybe Sue, that our parents are as burdened, at least, as those whose children have cancer. We're finding very, very high stress results, which probably doesn't surprise you. We have the patients complete a drawing sample because we're monitoring how their handwriting is going. Then we kind of all go into the room, and it can be kind of bewildering. At least we have 2 clinicians in the room. A lot of the time, I'll take some time privately since I'm the psychiatrist, and some of the parts of the exam I will leave for privacy of a different kind. But everybody's seen by the primary care nurse practitioner, by a psychiatrist, by a rheumatologist if it's relevant to their complaints or if the physical exam suggests it's important. We offer a visit with the educational consultant. Of course, we have a translator if necessary. And our research assistant will approach them to see if they would like to participate in research. Even though I said that we don't take people unless they are going to be probably appropriate research subjects, it's not required. Your care doesn't depend on whether you participate. In our physical exam, we look for infection, of course. We have found that there are some findings on the neurological exam that you've heard earlier about. We're surprised how much pain we're finding. Joint pain, but myofascial pain, I mean where the joints are, where the muscles are attaching to the bone. We have to ask about hallucinations, suicidality, homicidality, because if you don't ask, then you might not find out. Someone asked either yesterday or today, how do you get the kids to talk about these kind of horrible symptoms they can have? And I think the SciBox questionnaire is a really good thing. It's a list of symptoms many people with OCD have. Another thing to say is, well, sometimes, or some of the children who come here have trouble with, for example, seeing things but they're really not there, or hearing someone talking or hearing something, but actually there's no one in the room. So if you put it on the table as, yeah, sometimes this happens, I think that can give permission for the child to say, yeah, if they do. Lab is pretty much what you would expect, having heard everybody talk. Because of our database collection, we've been able to write up and publish our first 47 cases, but now we've had 3 times that many, and we'll be continuing to evaluate that. Here's just some of our data of the patients that we're seeing. Now, we didn't have the same criteria for a couple of years for people coming, so you can see here that when we started, the average time between the first symptom and their visit was 3 years. We don't have to have someone who's just had symptoms abruptly and severely start recently. A severe exacerbation would also allow them to come into the clinic. Most of our patients have had a relapsing and remitting course. Majority have had evidence of active or recent streptococcal infection. Lots have had sinusitis issues, and some have had mycoplasma IgM titers being high, but I don't think that's not diagnostic, and because it's everywhere in the population, and it might be one of those true unrelated, but it could be contributory. 20% had a long time trouble with PANS and a deteriorating course. Even though they'd had this, a quarter of them improved on prophylactic antibiotics and getting the strep out of the house, which is really hopeful to me. Someone had a long course. There are some things that you could do quite easily, and a number of them really helped. And 50% appear to improve with immunomodulatory therapy, but that's as strongly as I can state that. Most of our PANS patients had pre-existing psychiatric symptoms. And I can't tell you why. If you think of what Tanya's been talking about with the school children, it could be that. It could be that we saw them after they'd had episodes that hadn't been caught, and we saw them after an exacerbation. And when we saw them, they were quite more of them had psychiatric symptoms too. And the expected physical, somatic symptoms. The pain was on questioning. They didn't come in and say, oh, I hurt. Almost never. It was not in the front of their minds. Sleep abnormalities were very prevalent, with people waking up in the night, having trouble going to sleep, terrible nightmares. Well, just saw someone last week, they said, well, their child does kung fu in the night. No, they didn't really mean that, but if you look at the covers, or if you're sharing a bed, which makes sense if they have separation anxiety. That's, you would know. They would have a shifted sleep cycle. And interestingly, we're also seeing what has been seen elsewhere at the NIH, that when you go into dreaming sleep, you're supposed to not be able to move. But these people do move while they're dreaming. Just another emphasis on these questions should be asked. Many of our patients, certainly a lot more than the general population of children, right, had suicidal ideation, homicidal ideation, or gestures, or an intention to kill somebody, had been violent to themselves or objects, and a quarter of them recounted that they had had psychotic symptoms. Now, they may not have volunteered that, but on questioning, find out. About a quarter of them at least met criteria for a pain processing disorder. This would be like fibromyalgia, for an example. A quarter had inflammatory back pain symptoms or arthritis. And I'm not going to go into the immune markers. 10% had a bona fide immunodeficiency. Now, if you have a diagnosed immunodeficiency, that's combined variable in immunodeficiency disorder, the treatment is IVIG. So that would be something interesting to know, especially, or tell the insurance company. 62% had first-degree family members had some sort of inflammatory disorder, whether it's back or joint pains and symptoms, inflammatory bowel disease, reactive arthritis, psoriasis, and others. Our future is, we hope, to continue to see patients, conduct research, hope to help many patients, and I hope to see more patients, participate in the development of treatment guidelines, which is imminent, and expand our staff. As we show financial viability, I went in to talk to the head of my division. He said, well, you must show more than 100% productivity, and then we will consider increasing your time. So we have to show it. That's real world. We have to show productivity in research to continue to get funding. These are some of the ways we are collaborating in research. Dr. Frankovich is just like a Dash in that movie, running around campus talking to all the researchers and trying to get them involved. She's having good success because if we are seeing a pretty homogeneous sample of people affected by a trouble that changes, so we can monitor it, it's a very attractive population for researchers in a number of disciplines. It's really helpful to have a multidisciplinary clinic. I can't overstate that. It's really helpful to have experts in a variety of areas bringing in their expertise, which really is different than each other's. And we really work as a team. It's so wonderful to be able to be in the same room, or either a conference room or the exam room, and talk about what to do, what we think. Did you look at this? Listening to each other's history taking. And we can plan treatments together for this very complex trouble that affects so many systems. We can coordinate care better because there we are versus setting up a phone call for next Thursday at 1. And that would be really good if you can set up a phone call next Thursday at 1 in terms of helping healthcare providers coordinate with each other, or accountability to each other. I don't think we're trying to do anything wrong, but it's helpful to know, yes, I'm going to take care of that today, and you're going to. We review each other's work, and we collaborate. We meet every week and go over patients that we have questions about, deliberating about. And we hope to be innovating all the time. Let's add this to our history. Let's add this to our lab work. Let's add this to our physical exam as we learn more things. But if you don't have a clinic, just to tell you some of the things that physicians who are working solo, whether they're in their own office or in a big place, but working solo in terms of being with PANS patients. Should they really take on these patients? Because you don't know much about, is this a diagnosis that I know about? Is it a diagnosis that, am I going to treat outside my specialty? That's not comfortable and maybe not wise. To whom can I refer these patients for the rest of the treatment? Should I just now become an infectious disease doctor as well as a psychiatrist? Well, that's a big that's almost impossible undertaking. And should you use treatments that are off-label, meaning use treatments for which there's not maybe satisfying enough amount of evidence, research evidence? So I'm just saying that there are practitioners that may feel uncomfortable with taking on this. But if you don't have a clinic, what are you going to do? Where are you going to get treatment? Where are you going to get appropriate treatment? How are you going to coordinate care? Well, you know you need at least 2 people. You know you need a primary care physician, nurse practitioner, and you need a psychiatrist or a psychologist, because they have expertise in different areas. So here's what I think could be ideas that might help you in your community either get a physical PANDAS clinic or at least a network of interested clinicians who could collaborate. Well, first off, if you find physicians who are familiar with PANS, become familiar with them. Parents really have to become the case manager, which is a hard thing to ask since you may not be sleeping very well. You may be worried about just getting through the day, trying to get your child to eat something. But you're the most expert on your child. You have the most energy, passion, of course, in helping your child. And with the state of where things are, that's where the responsibility and the necessity lies. I would say facilitate communication between healthcare providers. Generally, you don't get paid, as a physician, you don't get paid for time making phone calls, writing emails, and most physicians are quite busy. So it really takes something to help them communicate. And they want to, I believe, and they are, it's hard to do. You know, someone's going patient to patient to patient all day. When are you going to fit in a phone call? That's just not easy. Or a meeting. So you might help them schedule joint visits, maybe phone conference calls. During our visit, could you bring in the conference phone? Dr. So-and-so would like to hear what we're talking about and has a few questions. I think that could be reasonable if if the person you're in the room with would think that's acceptable. Deliver the medical records. They're invaluable. It may be, I mean, certainly there's more with one way to do it, and the institutions can do it, but if you volunteer, it will be done more likely and more quickly. Provide physicians with as much information as they will take about PANS. Tell your physicians about other physicians in your area who have been involved with treating children with PANS. Now, here's one of my favorite ones. It's a silly thing to me, but I have found it true. Physicians, you know, can make a fine living, but they still carry, okay, this is my opinion, kind of a deprivation syndrome from their training. And so you couldn't pay most physicians to come to a luncheon or like spend 1 or 2 hours of their time listening to a lecture, you know, having a networking meeting. But if you provide free food, it's goofy, but I think more people will come. So You can blame me for this silly idea, but, well, the drug companies have known this for a long time. If you could scrape up, I don't know, you could cook your own food, whatever, but a physician journal club or a physician interest club, and you feed them, or dinner, or breakfast, I think it could be helpful. Of course, if you don't have one, start a parents' support group, or even bigger than that, a group like this. If you find a physician or hospital administrator who is enthused, help them network, help them fundraise. So I had a lot of fun doing this, except for the fact that it's a real burden to be the center of this flower. But these are the people with whom parents are likely to need to interact in no particular order. The school, the teacher, friends. Call on your friends. People, in my experience, don't really get a chance to help other people very much. And often, people will be so delighted that you ask. It's an opportunity for them to do something nice. So, of course, use your own judgment, but I think that would be a reasonable thing to do. Obviously, you have to talk to the pediatrician. Your own family can be supportive. You may need an ear, nose, and throat doctor. Take a look at the sinuses. Take a look at the sinus MRI. Support groups, rheumatologists or immunologists. If there's an immunodeficiency, meaning the immune system is not working properly, that's important to understand. If there are joint problems or other kind of autoimmune problems, that's important to know. Other parents, that would be obviously very helpful. There's nothing like feeling understood and finding more information. A psychiatrist, community, that would be more maybe when you have enough energy to try to help inform others and support others. And psychologists for CBT. And I think when things have evened out, psychological testing, or perhaps better, neuropsychological testing. Because if you understand the particular troubles the child is having, you have a better chance to help both in your own life with the child to understand the reason the child is or isn't doing a particular thing, but then again, then also translating that for the school. I don't have any potential conflicts with this. Dr. Frankovich and our research effort of the PANS Clinic received research support from the NIH, the PANDAS Network, the PANS Physician Network, and the Loop Foundation. I don't know if I have time for questions or not. Okay. Thank you. If someone has them. Well, that's either good or bad.